Hormone replacement therapy might be one of the most misunderstood treatments in women's health. Some women are still genuinely afraid of it. Others swear they wouldn't survive without it. But what is hormone replacement therapy really? Who's a good candidate? Should anyone avoid it? And what types of hormone replacement is out there? Patches, pills, creams, pellets, and what actually works in real life practice?
In today's episode, we're asking Dr. Caroline Day, menopause and hormone therapy expert, all of it. And yes, we finally tackle one of the most common listener questions we get. Why are hormone pellets so expensive and why aren't they covered by insurance? If hormones feel confusing, controversial, or just plain overwhelming, this episode is for you. Let's dive in.
Caroline J. Day has been a physician for over 35 years and is board certified in family medicine. She graduated from the University of the Witwatersrand in South Africa in 1988 and went on to gain extensive experience in pediatrics, urgent care, psychiatry, and geriatric medicine while living and working in South Africa. She also practiced in the United Kingdom in hospitals in and around London. In 2002, she and her family relocated to Tuscaloosa, Alabama, where she continued her medical career in the United States. In 2015, Dr. Day became board certified in anti-aging and regenerative medicine. She is a member of the American Board of Family Medicine, the American Medical Association, the Medical Association of Alabama, the Menopause Society, and the American Academy of Anti-Aging and Regenerative Medicine. In February of 2017, she opened Tuscaloosa Integrative Family Medicine in Northport, Alabama, fulfilling her dream of creating a practice that provides exceptional primary care for both acute and chronic medical conditions, as well as hormone therapy and personalized weight loss care. Her passion is preventative and integrative medicine, helping patients not only live longer, but live better. Her approach blends evidence-based traditional medicine with modalities such as bioidentical hormone therapy, nutrition supplementation, and detailed life-changing patient education. Dr. Day has been awarded top family physician in her local area for the past 6 years and was recognized as the top family physician in the state of Alabama in 2022. In 2024, she completed a fellowship in anti-aging, metabolic, and functional medicine and became a Menopause Society certified practitioner. Outside of medicine, she enjoys traveling and bicycling with her husband, watching movies, baking, and spending time with her adult children and elderly father.
Dr. Day also happens to be my physician and my favorite healthcare provider, and she has been overseeing my hormone replacement therapy for several years now. Dr. Day, thank you so much for being here, for coming to the studio. Brierley has heard me rave about you and your practice and your knowledge for 5+ years now.
Mm-hmm.
Yeah.
Yes. And anytime she has an appointment, I always we have a full download after the appointment.
Yes, because I love going so much.
Well, you always learn something, and
Yes,
she's
I
like,
do.
"Let me tell you what I learned." I mean, we're not talking about the ins and outs of the appointment.
Yes, true. But thank you so much for coming. And perimenopause and menopause has become such a big popular topic everywhere, but particularly among our listeners. And we've had questions for at least 2 years now about hormones and hormone replacement therapy. And I just kept saying to Brierley, we are not the ones to talk about it. We can do research,
Right.
but
Yes.
we are not the experts here. We need to find the perfect expert. And then we thought of you, and you agreed, and we were just thrilled to have you to...
Well, thank you. Thank you so much, Carolyn. And it's nice to meet you, Briley. And it's my absolute pleasure being here.
Thank you. Okay, so let's just jump right in. You hear the term hormone replacement therapy. You may hear it HRT.
Mm-hmm.
What exactly does that term refer to in general?
Okay, so the most common way that we would refer to it with hormone replacement would be looking at menopause hormone replacement therapy. And that includes anything like progesterone, testosterone, estrogen. We replace hormones all the time, like, for example, in hypothyroidism, Synthroid is you're replacing the thyroid. So it's, what your body's not producing. Or if somebody has low cortisol, we replace that. So
People can actually have low cortisol.
yes,
Not in our age group.
yes. I know.
I couldn't resist.
Yes.
That makes sense. I just was thinking of hormone replacement specifically to female hormones.
To female
and
hormones.
menopause.
So, for example, for men, it would be testosterone replacement therapy. So it's any hormone replacement therapy is replacing any hormones in the body that are deficient, basically.
In regard, well, let's just tell listeners we're going to be talking about hormone replacement.
Female, yes.
Geared towards females in perimenopause and menopause.
Menopause, correct.
I feel like, and maybe it's because of my age being in perimenopause, but that we're just now hearing a lot more about hormone replacement during that period.
Right.
And that there are a lot more options compared to even 10 years ago. And can you give us, I feel like that has to do with some controversy in the past that our mothers and women older than us were told this isn't safe?
Correct. And yes, so the whole controversy surrounding hormone replacement therapy for women in menopause really started in around about 2002 when the Women's Health Initiative was doing a study looking at the effects of estrogen and progesterone and the risk profile. But they were using synthetic hormones. So it would have been Premarin, which is actually estrogen that comes from the urine of pregnant horses. So that's why it's called Premarin. It's actually pregnant mare. So Premarin. Okay. So that estrogen has about 17 odd different side chains compared to the estrogen that we as women produce naturally. And then they were using progestogens, which are synthetic progesterones, which are biochemically different. So most women, prior to the Women's Health Initiative, were being put on synthetic hormones, i.e. Premarin and Prempro. So you would have to have estrogen and progesterone if you had a uterus. So you either got Premarin, which was just estrogen alone, or Prempro, which had the synthetic estrogen plus the synthetic progesterone. And over the 2-year period that they actually did the study, they found out that there was an increase in blood clots, heart disease, stroke, and breast cancer. There was actually a decrease in uterine cancer and bone density, were probably the only two positives that came out. So, in fact, they actually stopped the study, and with overnight, all women were like just yanked off their hormone replacement therapy and told, that's it, it's far too dangerous. So,
and that was it.
And that was it. And so what happened after that was women just got put onto things like antidepressants, ADD medication, blood pressure medicine to handle hot flashes, lack of focus, depression, anxiety, all that kind of thing. Yeah. But women then really were struggling so much that then doctors started saying, okay, we'll give you lower doses of these for shorter periods of time to try and cope with it. But unfortunately, this did a huge disservice because really for the last 20 years, there's a whole generation of women who haven't actually been on hormone replacement therapy. Mm-hmm. And in my practice, I'm now seeing what I think is one of the fallouts of that is the amount of dementia that I'm seeing. So almost without fail, all of my friends' moms have got dementia. Now they kind of, my friends' parents are reaching sort of 80s and 90s. Mm-hmm. Also, most of the women that come into my practice now in the 80s, 90s have some form of cognitive decline. And none of them have been on hormone therapy. And estrogen has been shown to be extremely neuroprotective.
Yes.
So I'm not saying that the synthetic hormone was the correct one to be on.
Right.
But what happened as well, from a positive point of view with this Women's Health Initiative, it sort of forced practitioners to go back and look at bioidentical or natural hormones, or hormones basically that our body produces. Now, the problem with that is none of the pharmacies are making, all the pharmaceutical companies can make money out of it because it's like supplements. If it's a natural product, they are not going to be able to market it, and
they can't regulate it and patent it.
Correct, and it doesn't go through FDA approval, etc. But it's not a moneymaker, for want of a better way of putting it. But bioidentical hormones have been used in Europe way before the synthetic hormones came on the market. The synthetic hormones came on the market around about the 1950s, 60s, once the birth control pill came out. And the reason for the menopause synthetic hormones was because they could be manufactured by a pharmaceutical company and there was a profit involved. Mm-hmm. So all the bioidentical hormones kind of just went by the wayside. And because they're not FDA approved or available from pharmaceutical companies at that time, there are some now, which we can talk about a bit later. But so there was a whole sort of movement amongst more sort of functional medicine, integrative providers, compounding pharmacies started getting onto it. And so there was a move towards bioidentical or natural hormone therapy. And the interesting thing now is that there's this huge amount of literature which irrefutably shows that estrogen and particularly progesterone as a bioidentical is actually protective of breast cancer. So the biggest issue I see with women's fear of going on hormone replacement is the fear, I'm going to get breast cancer. Mm-hmm. And that's because our mothers, etc., 20, 30 years ago were getting breast cancer because of it.
But they weren't bioidentical.
But it was bioidentical.
Yes.
And it's particularly the synthetic progesterone that is the big problem for breast cancer. In fact, causing the risk for it.
Can I ask 2 questions?
Yes.
Okay. Sorry, for some listeners know I'm like over here raising my hand like I'm at school.
I know, I'm fascinated. I'm like, woo, the best lecture I've heard in a long time.
When you said, two things. Mm-hmm. When you said that physicians started putting them on lower doses for shorter periods of time a couple decades ago.
Yes.
Was that using
the synthetics?
The synthetics.
Yes.
Okay.
Yes.
Then my next question for you is there are forgive my lack of knowledge here. Do you treat pregnant women?
Well,
do you have any in your practice?
Yes, I have. I mean, I do. Yes.
Okay.
But I'm not doing the antenatal care or anything just because, if you are pregnant, you usually do that with your OBGYN.
Yeah.
But yes.
So my question was, some women, when they're trying to get pregnant or stay pregnant, you get some version of progesterone given to you.
Yes.
Did you take it?
Yes.
Yes.
And so my question is, what kind of is usually given? Because I think some people get it as a shot. Correct. Maybe some people get it as a suppository.
Correct. And most of the time, it's
the
synthetic one. Yes.
Okay.
But yes, it is.
If you had that, priorly did, is there a reason to worry, or was it for such a short period?
Well, that is a very interesting question. I actually need to look at that and do a little research into that.
We threw that at you.
No, because it would be nice if we could use the actual natural progesterone. So progesterone is available now. Drug companies produce it. It's called Prometrium, and that is micronized progesterone. So one of the reasons there was a difficulty actually producing progesterone as a capsule was because it couldn't be absorbed that well. But they developed some technology and they micronize it, so we can use it now orally as a capsule.
I mean, that would have been much better than the route I had to go.
Correct.
Take my 200 milligrams every night.
And those injections that they give you are very painful because they're in an oil base. Oh. They tend to be.
Yeah, I had the suppository, so I was grateful that I didn't have to do the injection. But let me tell you, that did greater things to my mental state than any pregnancy hormone coursing through my body.
Mm-hmm. Okay, so thank you so much for explaining the controversy.
Oh, fascinating.
Yes.
Yeah, it really is. And unfortunately, it sounds like a lot goes back to what's a moneymaker and what's not, and then just the lack of research in general on women and hormones. I want to get a little more into when you say bioidentical, what do you mean by that?
Right.
But I also want to touch on real quick, just as a reminder to our listeners, because we've covered perimenopause and menopause. But in general, going through the perimenopause phase to get to menopause, where you haven't had a period for a year,
Right.
your estrogen drops, your progesterone drops, or are they typically in fluctuation during that period? And what goes first?
Yes.
typically?
Okay. So typically women go into perimenopause around about the commonest age I get in my practice is 43. Almost,
wow.
yes.
Interesting.
It's so interesting.
That's Briarly.
Right, yes.
Dr. Day, when can I make an appointment to come see you?
I gave you the paperwork 5 years ago.
I know.
I literally printed out your paperwork for her.
So, but it can start as early as 35. Okay. So, depending just on, your genetics, your lifestyle, stress, whether you've had any surgery, had a hysterectomy, a tubal ligation, those kind of things. But so what happens with perimenopause is you start losing progesterone and testosterone.
Okay.
So perimenopause is officially sort of classified as maybe when your periods start changing a little bit. So maybe they become a little irregular. Maybe they become a little heavier, a little lighter. Just you start noticing some changes with it. Okay. And so what happens is you might miss an ovulation in a cycle. And when you don't ovulate, what that means is you don't get that second, in that day 14 to 28, you don't get the progesterone surge. So when those progesterone levels start dropping, that's when women start noticing that they're getting a little bit hot at night, having to kick their leg out of the cover, or they're sweating, or it can be as bad as you have to change your sheets and your pajamas. You also start noticing that maybe you're a little bit more anxious. If you've got anxiety, just baseline, and then your progesterone starts decreasing, your anxiety is going to ramp up. It also contributes to much more PMS. So a lot of women will start saying, I've hit 40, my PMS is absolutely awful. That week before, I'm irritable, I want to jump out of my skin. I don't want anybody near me. My kids don't want to, they're wondering why I'm so irritable. I have short temper, that kind of thing. And the thing about this is it doesn't happen every month. You might ovulate the next month and then you feel fine. And you kind of wonder, now I'm back to normal. You might have 2-3 months where you feel great, and then it comes back again, and you're like, what in the world is wrong with me?
Which just makes you feel like you're going a little crazy.
Exactly. And perimenopause is, it's like being on a roller coaster. It's up and down. So you
hate roller coasters.
Mm-hmm. So you have months where you feel good and months where you don't feel great, and you're kind of just wondering what on earth's going wrong with you. Progesterone, when it's low as well, with the night sweats, interrupts your sleep, so that doesn't help either. And then all of that is just because you develop a thing called estrogen dominance, not because you're having too much estrogen,
just mention this,
but because your progesterone levels are low. So the estrogen's a little bit too high in relation to your low. Yes. And so we often use progesterone, bioidentical progesterone, either in a cream or capsule, to balance that out so that you can feel. Yes. So that's, yes. The other hormone, as I mentioned, it starts decreasing, your ovaries start producing less of it, is testosterone. And so that's a big one, which hasn't been recognized really until maybe the last few years or so. And that's when women come to me and they're like, oh my gosh, I'm so exhausted. I don't know what's wrong with me. My sex drive has gone. I don't care if my husband comes near me or not. I've got brain fog. I used to be in the gym easily in the mornings, afternoons. Now, when I get home after work, I just want to lie on the couch. I don't have the motivation that I had for exercise. And when I do exercise, if I can get myself in there, it takes me longer to recover. And then my muscle tone is decreasing. That is all low testosterone. And that's part of perimenopause. So we often will balance the hormones. It's not so much replacing the hormones, but you try in perimenopause, we're balancing. So yes, we do replace some testosterone, progesterone, but it's just to kind of balance this crazy roller coaster that you're going on. And perimenopause can last really anything from about 8 to 12 years. It just depends when it starts and when you go into menopause.
Okay. So I've been getting testosterone and
Yes,
progesterone to you for several years now.
Yes.
We just recently started adding a little estrogen.
Correct.
Does that mean I'm in menopause and I don't know it?
No, so you are at the premenopause,
Okay.
which is kind of that 12 months
you
or
graduated.
So. Yes, she's graduating, yes.
From peri to pre. Congratulations.
Yes, so that premenopause is the 12 months or so before you really hit full-blown menopause.
Okay. Well, it's been a game
Wait,
changer.
12 months until she hits full-blown menopause?
Yes, roundabout. Yes.
God, I can't wait for you to tell me all about that.
Yes. And that also can be a little roller coaster because what we often find is you might come to me next month and say, oh, I've had this terrible month. My breasts have been tenderness. I have been so PMSy. I absolutely I feel like I'm pregnant almost. I don't know what's wrong with me. And then we will measure your hormones and your estrogen level might be extremely high. And that happens in this 12 months before because often we have what we call these out of loop ovulations, and you can it's your ovaries are just releasing the last eggs, and you can do like release 1 or 2 and actually have like a double ovulation. So I've seen women's estrogen levels go up as high as 900 as if they're pregnant. And that is, and then they go, oh my gosh, I'm not in menopause, but actually you before menopause.
Yeah.
So it's just an interesting phenomenon that we see in that 12 months before full-blown menopause.
That sounds terrible.
Thank you. Well, you'll be with me.
I know.
Yes,
I know. I'm like,
and then I get to go through it all again with you.
There you go.
At some point in this interview, do we get to talk about what the partner should and shouldn't do? Because I feel like even though Carolyn's not my partner, like I need to be aware of what to expect. Like, you read the book, like what to expect when you're expecting. That's what Dr. Day is here for.
In pre-menopause.
Yes.
We'll come back.
Yes.
That'll be next time we have Dr. Day.
Yes.
Okay, so thank you for giving listeners kind of a reminder of what's going on. Okay, so we're going to talk about some hormone replacement, specifically the bioidentical. But first, we have had this question from several people wanting to know who is actually a good candidate for this. And maybe the better way to answer it, you can tell us, is who is it not appropriate for?
Okay. Alrighty. So, yes. So that's one of the commonest things I see. Patients will come in and say, oh, my friend's had breast cancer, or, she's over 65, or, she's maybe got some fibrocystic breast disease, and, my sister had a DVT, a blood clot in her leg. Would you be able to give them hormone therapy? And yes, those are all specific cases, and I treat all of that. For example, if a patient has had a blood clot, we wouldn't give any estrogen orally. Okay. So even if it's a bioidentical estrogen, it's still going to go through the liver with a first pass metabolism, and it can increase clotting factors. But it has been shown over and over again that if you use estrogen transdermally, i.e. use it with a cream or a patch or a pellet, where either with the pellets it goes directly into the bloodstream, with the creams and the patches it's going to go through the skin. So it's 100% perfectly safe to give it in terms of patients who've had a blood clot. And often patients of mine who are doing hormone therapy with us will have surgery and they'll tell their doctor, oh yeah, I'm on hormones. And they say, oh, come off it immediately. No, it would only be if you're on an oral estrogen.
Okay.
So
good to know.
Yes, the oral progesterone is not a problem in terms of DVTs.
Okay.
It's a completely different. It's just the oral estrogen. And then in terms of patients who've had breast cancer, yes, I do have patients that I help with hormone replacement who've had breast cancer, because most of these women are absolutely desperate. If they've had a hormone sensitive breast cancer, they get put onto tamoxifen or a different one of the other drugs similar to that, and it puts you straight into menopause. So not only they're going through chemotherapy, radiation, but now they've got horrendous hot flashes, vaginal dryness, no sex drive. They just don't feel like themselves at all. And often we can use a topical vaginal estrogen, and we can use vaginal testosterone, and we can also use testosterone. Testosterone's pretty safe when it comes to somebody who's had breast cancer, and it also depends on their genetics, and it depends which hormone they were sensitive to, whether it was estrogen and progesterone, just estrogen. But we monitor them very carefully, and they're fully aware of the risk benefit profile. So yes, even if you've had breast cancer, there is help. There's another medication that's come on the market called Veoza, which is really great for hot flashes, and I use that a lot in my hormone-sensitive breast cancer patients who are typically, say, on one of the drugs that has put them into menopause, and that really can help tremendously. So there are things we can do with that. Yes. Sorry, and I haven't even hit on the ladies that we can give it to, but anyway, yes.
Speaking of the patients who have had cancer,
yes.
Can you, because like you said, they usually have some type of surgery and treatment that sends them directly into menopause.
Yes.
I actually went through this with my stepsister. She had ovarian cancer. But anyway, can you take anything when you are in treatment, or do you have to wait until you're out of treatment?
That's a good question. I do it with both sets of patients.
Okay.
Yes. I mean, and it depends. I'll have patients who come to me in it and they say, I can't live like this anymore. I don't care if there's a slight risk. I'll sign some paperwork, covering that, saying that I understand the risk, but I need something.
Yeah.
But then obviously if they're estrogen positive, I'm not going to give them estrogen.
Right.
But as I say, we can use testosterone, and you can actually use vaginal estrogen. We actually use a different estrogen for the vaginal one. We use estriol, which is actually an E3, and it's very safe in terms of breast cancer. And there's quite a lot of research going on with that as well, which is good to know.
Yes. Yeah.
In terms of the patients that need it, without a doubt, the patients that I do most of my hormone replacement therapy are women that come to me in full-blown menopause and they're absolutely desperate. They're coming in and they've got the hot flashes, the night sweats, the mood changes, the vaginal dryness, the low libido, the brain fog, the anxiety, the mood changes, the emotional lability, and they're like, I just can't stand this anymore. Please help. And so without a doubt, the hormone replacement therapy for them is wonderful in terms of symptom relief and getting your life back and actually getting yourself back.
Yeah.
But the even more important hormone replacement therapy is really for all women once they're in menopause, because it's not just the symptom, it's the whole anti-aging, disease, chronic disease prevention as you go forward. So, women can now spend about 40% of their lives in menopause.
Wow.
Because we're all living longer.
Yeah.
So, I mean, women 100 years ago used to mostly be dead by their 50s and 60s. Now we're living to 80 and 90. So if you're going into menopause, say, around about 52, that's 30, 35, 40 years almost in terms of menopause. And so the literature is very clear in terms of the benefits of hormone replacement in terms of protecting your bones against osteoporosis, protecting your lean muscle mass, helping with weight, helping with brain protection, heart health, vaginal health, breast health, etc., etc. So I can see a clear difference in people who do hormone therapy. It's almost like they age better by about 10 years. You can you can see people who are having hormone. They feel better. Often their hair's better, their skin's better, their eyes are brighter, they've got their vitality back. And as one of the professors in one of my hormone classes was telling me, it keeps you out of the nursing home. I mean, the 3 commonest reasons for landing up in a nursing home is a broken hip. So hormone replacement, particularly estrogen, helps prevent the osteoporosis, which leads to that. The second thing is frailty, or, in medical terms, sarcopenia, which is the loss of, your strength, your muscle mass. And then the third biggest reason for people ending up in nursing homes is dementia. And there's more and more research coming out now in terms of the protection of estrogen and progesterone in terms of neuroprotection and helping protect the brain.
Wow.
So that to me is even a bigger reason. So often patients will come in with who are in full-blown menopause, and I will treat them maybe with slightly higher blood levels. And then once they transition out of that and they start getting into their 60s and 70s, we may transition to lower doses of hormones, more as an anti-aging thing than symptom relief.
And when they transition, right, and they're getting to a good regimen, is the frequency of follow-up, does it decrease?
So
because it seems like in perimenopause, I mean, you go, every few months, right?
Yes. So when we prescribe testosterone, we have to see you every 6 months, just because of a DEA thing. I can't give a refill on your creams or anything for longer than a 6-month period.
Got it.
So basically, yes. So the longest I really see anybody is 6 months. And then, for example, if we're doing the pellet therapy, that would be every 3 months. And then also if a woman's going through perimenopause or premenopause, we're not quite sure what's happening, I'll bring her back in 3 months as opposed to 6 months to remeasure her hormones and see where she's at.
Yeah. And you're great, too, about just saying, I want to test your levels. So
yes.
I'll just get my blood work done.
Yes,
and
yes, absolutely.
Or something doesn't feel right.
Because a lot of the problems with, a lot of more the, say, old-fashioned OBGYN approach would be that patients are still getting put onto the synthetic hormones. And then they might only get seen once a year or every 2 years. And it's very common for patients to come to me and say they've never had their blood tested ever, apart from the one time where they were told they were in menopause. Wow. So they get put onto, and that was the other thing with the Premarin and the Prempro, they're all static doses. It's a one size fits all. You do have different dosages, but not the same as when you have the freedom of using a compounded product where you actually have a much higher range, a much wider range of dosages. Yeah. So we tend to personalize our dosages. So what one person gets is going to be different to another person. And then obviously menopause in full blown would be different to, say, postmenopause or premenopause or perimenopause. So it's really nice to be able to have the flexibility to dose it individually, as opposed to we're just going to put you on, say, Activella, which is a product, looks like a birth control pill. It's got the estrogen with the synthetic progesterone in it, but it's just a dosage. So you'll get the same one, you'll get the same one. And then often, labs aren't tested because a lot of physicians will say, we don't need to test it because we know you're in menopause. But they're not looking to see how effective that dosage is. And we can often tell from hormone levels, especially the FSH, how effective it is. And I tend to go on more, you tell me how you feel, and I can adjust the dose accordingly. I don't just go strictly blood levels. We also go according to how patients feel and kind of what's an optimal dose for you.
I love that. I think that it is not easy to find a physician who will talk to you about how you feel side by side with your lab values, really for a lot of things.
Yes.
And when you're talking about any type of condition, obviously in this case perimenopause, but any type of condition that has is relative to how your body feels and operates.
Yes.
Most women know when it's not
correct.
Right.
And yes. And one of the things we do a lot of that with treating our thyroid patients is, I'm not going strictly on thyroid numbers. It's really important when you treat thyroid is how do you feel? And a lot of my patients can tell almost immediately, oh, I like this dose because of X, Y, and Z, or when my levels become this, that's happened, this is how I feel. But that sort of lab value might not do the same for somebody else. So it's difficult when you just say, oh, well, these are the lab values and this is the normal, but why do you feel terrible? And so, you have to sort of balance it between how the patient feels and the dosage and kind of play around a little bit with it to get it to where it needs to be optimal for the patient.
That's one of the things that impressed me so much when I started going with you is I realized you were one of the first doctors that I've had who didn't just look at what LabCorp had defined as normal.
Right.
You interpreted them all and interpreted them together and based on how I felt.
Yes. And so one of the things that's quite interesting, and this is with male testosterone, is the lab values have changed over the years because men now have much lower testosterone levels than they did, say, 10, 20, 30 years ago.
Why is that?
So, and that's a whole nother thing in terms of, the environment I think that we live in.
I was going to wonder, I was going to ask you if it was the environment and our exposure
to all the chemicals and the Zen estrogens and all that kind of thing. So what happens is when they make a lab value, they're going to pool blood and take an average. So now they will say that it's normal. A level of 300 is normal. But whereas maybe 20, 30 years ago, men's levels were 700, 800 would have been a normal. So,
So quote unquote normal does not necessarily mean optimal.
Correct. Or a specific lab value.
Yes. Okay. That, yes. I have a lot of personal stories as it relates to that. We could just eat up all of that for days time.
Okay.
Not testosterone, just feeling versus lab values.
Yes.
Anyway, so let's move on.
To what I think people probably really want to know.
Yes.
And what are the different forms or types that you use that you found to be the most effective?
Yes. So in my practice, we only use bioidentical or natural hormone therapy. So that means the testosterone that we use is just testosterone. The progesterone that we use is progesterone. As I say, it's usually micronized. And then in terms of the estrogen, we'll use either estradiol or estriol or a combo of those two. So you can get it in all different forms. I know a lot of people will just think, oh, it's just pellet therapy. It's not. You can use estradiol does come as a bioidentical now as an oral, and I do use it in certain cases. It's not my first preference, but it is available for whatever reason a patient wants it. The progesterone will come as you can get it in a cream, you can get it in a troche, you can get it in a capsule. The testosterone, we do not use any of it as a oral. There's still a medication called methyl test, which some of the older OBGYNs still give women. Testosterone by mouth is not good for the liver. It's been shown to increase liver tumors. So it was taken off the market years ago for men. It has not been taken off the market yet for women.
Oh, my God. I'm going to interrupt here. You can get it at a compounding pharmacy.
No. So the methyl test is produced by a pharmaceutical company.
Oh, you're talking about a specific variety of testosterone.
Yes,
I thought you were talking about testosterone just as a
like a troche. Yes. So the testosterone you can do as a cream, you can do it as a pellet, you can do it as a troche.
But there's a brand. You're talking about
an FDA-approved brand.
Yes, which is Estratest. Yes, and I do still have some older ladies coming in, and then I'll take them off that, and I will transition them to natural testosterone. And then, of course, estrogen, you can also do it as a patch. The patch has got a lot of attraction right now. Mary Claire Haver, who's really big in the sort of menopause space, she uses it. So a lot of her patients, a lot of her readers would like to use it. The problem with a patch is you either use it once a week or you use it twice a week. A lot of women are allergic to the adhesive. So you have to move it around. And then, of course, people who are doing a lot of sweaty sports, exercise, it's not ideal for that.
We would not. That would not work well for us.
No, and the only way I use the patch is just the estradiol patch, because you can get the patch with the estradiol, which is the natural or bioidentical. But if you use the patch with the progesterone, unfortunately, the progesterone in the patch is only available as a synthetic progesterone, which is why I don't like the combi patch, because of the synthetic progesterone. So I would tend to use tell a patient to use an estrogen patch and then use the progesterone as a bioidentical by mouth. So I use all forms of hormone delivery, and it really depends on the patient. And often patients will experiment and try different ones and just come up with something that suits them.
Yeah.
How do you feel about estrogen cream as a suppository?
You can do it as a suppository.
Yeah.
You would need to do it probably twice a day to get the best effect with it. And then,
that's exhausting.
Yes. And so, a lot of patients don't really like the vaginal route. Most of the time, if I'm going to do estrogen vaginally, it's a topical cream that we're going to use. Say, for example, a lady comes in and she's in full-blown menopause and she's totally miserable and she's going to do pellet therapy. I may still add a topical estrogen cream to the vaginal area for the next 3 or 6 months, just to help that whole area just heal up and get back to normal, so to speak. So sometimes we use it for that. So that's easier to use than suppositories. And
Yeah.
So
I have so many personal questions, Dr. Day.
To touch on pellets, just for people who aren't familiar,
yes, correct.
Pellets they look almost like a little grain of rice.
Yes,
or
correct.
Smaller.
Little tic-tac grain of rice. They come in different sizes because they have different dosage forms, which is nice because you can personalize them. Yeah.
And they just go right under your skin.
Right under the skin, a tiny little incision. Pop them into really the fatty part of your hip is the commonest area that we put it in. Yeah, and you can't really feel them. It's, as you know, it's like a 10-minute quick, easy procedure.
It's less than that, I feel like, because I always wish I had more time with you. You're in and out. You're good at it. So I go every 3 months to get pellets that of testosterone and a little bit of estrogen. And then
and then you take the progesterone orally. Yes.
One of the critiques I have heard about pellets is that they don't always release evenly. Is that true?
Well, no. Usually what happens is, for example, in women, it'll usually start, you pop them in and it needs to get a little blood supply around it, and then they will slowly release into the bloodstream. They're pretty compressed and hard, so they're not going to sort of disintegrate or anything like that.
Yeah.
And the female ones usually last about 12 weeks. So you'll usually sort of get coming up in that first week or two to a peak, and then it'll usually be pretty steady. And then as they slowly sort of
empty.
Yeah, they will it'll drop down. So most women can start feeling it around about that 10, 11 week mark. They can tell that they're starting to drop off.
I can do that, and I'll look at my calendar and be like, oh, I have an appointment to get pellets again in 2 to 3 weeks.
Yeah.
Makes sense.
And so most women will start saying, oh, yeah, my husband said it's time for my pellets. Or my child said, oh, mommy's a bit grumpy. It's time for her that's pellet things that she gets. So.
Got it.
But the biggest controversy where pellet therapy got a sort of a bad name or rap, so to speak, is a lot of practitioners have kind of just done a weekend course on this. And the dosing, you've got to be really careful about the dosing. It's not, there is really an art to it as well. And so what was happening when I first started about 12 years ago with pellet therapy was I was getting a lot of patients coming from sort of just med spas and places like that, and they were coming in with the most horrendously high testosterone or estrogen levels. And that, and that can cause some side effects. For example, if your testosterone levels are too high, it can increase acne, facial hair growth. I mean, women could start getting their voices getting a little hoarse and that kind of thing. And so it wasn't properly, I can say that they weren't properly experienced in doing it. And so it really did cause a lot of the OBGYNs to sort of feel negative towards pellet therapy, rightly so, because they had patients coming in with these extremely high levels, and it's, super physiological, and it's not safe.
Yeah.
And so you do have to be careful, you do have to be experienced, you do have to have the blood levels, you do have to listen to the patient. And, you get a feel with different patients. Some people do better with the lower doses. Some people do better with the higher doses. It's so personal. But on the whole, the pellet therapy has been one of the most rewarding things I've ever done, just in terms of you can't really beat it in terms of symptom relief. So it really is really helpful for women who are coming in who are desperate in terms of the way that they feel. And particularly, say, for weight loss. Women will come in and they've had this terrible 10 to 20 pound weight gain just kind of overnight, especially around their abdominal area, their midriff.
Yeah.
The pellet therapy can get you feeling really a whole lot better within, about 3 months or so. Wow. And so it's much easier to lose weight once you feel better.
Yeah.
So I always say don't go on a weight loss program until you've actually got your hormones balanced. Because once your hormones are balanced, you can get to the gym again. You're not having some of those carbohydrate cravings. You're not as exhausted. You've got more energy to cook, to eat healthy. So that's where it's really nice. Once you can kind of restore somebody's hormonal balance, everything else in their life gets better. And so they start sleeping better, they start eating better, they start exercising more, they start socializing again. They're not just wanting to lie on the couch and not get out in the evenings anymore. And so then you can start putting all the other things into your life that help you to be healthy.
Yeah. Why are pellets not covered by insurance? Do you know? Or
Yes.
Okay.
Because they are not FDA approved, and so we have to get them from a compounding pharmacy.
Okay. Got it.
Yes.
And are they eligible for HSA?
Yes, and FSA. Okay. So, yes. And for men, there is a commercially available pellet. It's called Testapel, but it comes in really, really low doses, and insurance will cover that.
Shocking.
Yes. Yes.
Shocking.
Absolutely. Well, and they cover, say, for example, the testosterone shots. So go figure. In fact, even the synthetic hormones, Premarin and Prempo, can really run you quite high.
Really?
As a woman, yes. They most of the time, the hormone that you get that's produced by a drug company will have a higher copay. So it's,
Wow. Just...
Yeah, so it's
every chance
so
they get.
Spend money for like pellets that aren't FDA approved, but then you're also going to spend money even if there is something.
Correct. So it's worth spending a little extra on the safer product.
Yeah.
Yes. That's a very good point.
Yeah.
Wow. Thank you so much for joining us for the Happy Eating Podcast. I'm Briarlee Horton.
And I'm Carolyn Williams. If you liked this week's episode, then don't forget to rate and leave us a review on iTunes. And be sure to hit the subscribe button so you'll never miss a new episode. We can't wait to have you back at our table next week for a brand new episode. Bye. The contents discussed in the Happy Eating Podcast, such as advice, studies, text, graphics, images, and other material discussed or presented on the site or podcast, are for informational purposes only. Content is not intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your mental health professional or other qualified health providers with any questions you may have regarding your condition. Never disregard professional advice or delay in seeking it because of something you have heard on the Happy Eating Podcast.
If you are in crisis or think you may have an emergency, call your doctor or 911 immediately. If you're having suicidal thoughts, call 1-800-273-TALK, that's 8255, to talk to a skilled, trained counselor at the National Suicide Prevention Lifeline. If you are located outside the United States, call your local emergency line immediately.